Hello, everyone, and welcome to our first module on pneumonia. So pneumonia refers to an infection of the lung tissue, and pneumonia is an example of a lower respiratory tract infection. Lower respiratory tract infections include pneumonia and bronchitis. They're distinguished from upper respiratory tract infections, which are infections of the nasopharynx or the sinuses. And in terms of pathology, pneumonia occurs in three distinct patterns. We'll talk about all of these in the next few slides. These include lobar pneumonia, bronchopneumonia, and interstitial or atypical pneumonia. So lobar pneumonia gets its name because it's a form of pneumonia where the infection often involves an entire lobe of the lung, like the left upper lobe or the right lower lobe. And this is the classic form of pneumonia infection, and it's classically caused by the bacteria Strep pneumoniae. In fact, the way this bacteria got its name is because it commonly causes lobar pneumonia. The way lobar pneumonia develops is bacteria like Strep pneumoniae are acquired in the nasopharynx, and then they're aerosolized and they travel down to the alveoli. Once they get to the alveoli, pneumococci like Strep pneumoniae or other bacteria can begin to multiply. They can pass from one alveolus to the next through connecting structures called pores of Kohn, and once this happens, you get inflammation of the entire lobe, sometimes called a consolidation of the lobe. And even though this is called lobar pneumonia, it can progress to involve the entire lung in some cases. So on this slide are some depictions of right upper lobe lobar pneumonia. This is a cartoon of what it would look like here. The right upper lobe is filled with bacteria and inflammatory cells and pus. On the left side of the screen is what a right upper lobe pneumonia looks like by chest x-ray. You can see that you've got this whited out section of the right upper lobe, and it's clearly demarcated here where the right upper lobe is separated from the lower portions of the right lung, which are not infected. Lobar pneumonia progresses through four pathologic stages, so let's talk about those now. So the first stage is called congestion. This is what happens in the first 24 hours following infection. During this stage, the alveolar capillaries are dilating, and if you could look down inside an individual alveolus, what you would see is an exudate that's mostly of bacteria that are multiplying. This is the very early stage of a lobar pneumonia infection. The next stage is called red hepatization. This occurs 2 to 3 days following infection. The word hepatization means that something starts to look like the liver. And so this is called red hepatization because you get sort of a thickening and stiffening of the lobe, like what's shown here, and it begins to resemble the liver, but it's red in color. So in this stage, if you could look inside an individual alveolus, you would see an exudate that's not just made up of bacteria. It would also have red cells and neutrophils and fibrin. This exudate is called fresh, and that's because the red cells and the white cells are intact. They haven't started to degrade and break down. During this phase, the pneumococci are alive. All these stages were initially described in strep pneumonia infection, so I'll use the term pneumococci here a lot. So the pneumococci are alive in this stage, and the lobes look red. That's why it's called red hepatization. Gray hepatization occurs 4 to 6 days following infection. So once again, it's called hepatization because the lobe looks like the liver, but in this case, it's gray and it's firm. And what's happening in this stage is the exudate is made up of mostly neutrophils and fibrin, and the red cells have begun to disintegrate, and the pneumococci are dying. And because of this, it starts to develop this gray color, and that's why it's called gray hepatization. And then the final stage, which occurs a week or more after infection, is called resolution. The lobe of the lung that was infected begins to return to normal. Typically, there's very little scarring. Enzymes coming from cells within the alveoli will digest the exudate. And the very important cell type in this stage is the type 2 pneumocyte. It's high yield to remember this for step 1. These are the regenerative cells of the alveoli, and they are going to regenerate the lung tissue so that patients who have had a lobar pneumonia weeks or months later can actually have an entirely normal lobe after the infection. That's because of those type 2 pneumocytes regenerating or repairing any damage that occurred. Okay, now let's talk about a different pathologic form of pneumonia, and that's bronchopneumonia. So bronchopneumonia involves patchy inflammation of multiple lobules. So you don't get an entire lobe involved. Instead, you get little patches of inflammation. This is a cartoon of what it can look like over here on the right side of the screen. These little yellow areas are little patches of inflammation. On the left side of the screen is a chest x-ray of bronchopneumonia. This isn't as easy to recognize as lobar pneumonia. You can see some little white patches here. That's evidence of bronchopneumonia. The reason this has a different pathologic pattern compared to lobar pneumonia is that the infection primarily involves the airways and the surrounding interstitium, and the interstitium is the tissue that surrounds the alveoli. And this is the classic form of pneumonia caused by Staph aureus, although it can also be caused by other forms of bacteria as well. And then the third pathologic form of pneumonia is interstitial pneumonia. In this form of pneumonia, the inflammatory infiltrate involves the alveolar walls only. If you look at this chest x-ray on the slide of a patient with interstitial pneumonia, you can see these little white wispy sort of things that are spreading out from the heart sort of into the lungs. That's evidence of infection of the interstitium, the tissue that surrounds the alveoli. You can get a similar pattern in interstitial lung disease, which I talk about in the video on restrictive lung disease. And interstitial pneumonia typically has a more indolent course. Patients don't feel quite as ill as they do with other forms of pneumonia. This type of pneumonia can be caused by viruses. It's also caused by certain types of bacteria that are called atypical bacteria. This includes Legionella, Mycoplasma, and Chlamydiophilia. These bacteria have unusual bacterial characteristics, which I talk about in other videos, and they tend to cause this form of pneumonia. You'll sometimes hear the term atypical pneumonia. It's also sometimes called walking pneumonia. And this generally means a form of pneumonia that is milder and it's caused by atypical bacteria like the three I mentioned on the last slide. It's usually milder than strep pneumonia. Respiratory distress is rare, so patients are still able to walk. That's why it's sometimes called walking pneumonia. And on chest x-ray, you see interstitial infiltrates like shown here, just like what we talked about in the last slide. Okay, so that's the different pathologic types of pneumonia. Now let's talk about specific pathogens that can cause pneumonia infection. And I'll start by talking about pathogens that commonly cause pneumonia in children. So in newborn babies who are less than 4 weeks of age, the two most common causes of pneumonia are Group B strep and E. coli. And these are acquired from passage of the baby through the birth canal, so they're acquired from the mother. And in particular, Group B strep is less and less common these days because we screen mothers for presence of this bacteria, and we give them antibiotic prophylaxis if Group B strep is found. In children from 4 weeks of age to 18 years, these are the common causes shown right here. In very young children, like babies and toddlers, viruses, especially respiratory syncytial virus or RSV, are very common. Children can also get strep pneumoniae infection. And then in older children and teenagers, mycoplasma and chlamydia are common causes of interstitial pneumonia. In adults, the most common cause of pneumonia is strep pneumoniae. You can also see bacterial infection with Haemophilus influenza. And then all three of the atypical bacteria are also common causes of pneumonia in adults. Some other causes of pneumonia in adults are listed on this slide. So first of all, gram-negative rods can cause pneumonia. Bacteria like Klebsiella, E. coli, Pseudomonas. These are not common causes of pneumonia, but when patients have a very severe form of pneumonia, a gram-negative rod is often the cause. And these types of pneumonia often happen in hospitalized patients. So people are in the hospital for some sort of severe illness and they acquire pneumonia in the hospital. That tends to be with bad bugs like gram-negative rods. Staph aureus can also cause pneumonia. This is the classic cause of post-influenza pneumonia. So the influenza virus itself rarely causes death through pneumonia, but it can lead to a secondary pneumonia with Staph aureus, which is often the cause of death in patients who have a influenza viral pneumonia. Anaerobic bacteria can cause pneumonia. That may seem counterintuitive since the lungs contain oxygen, but anaerobes can infect the lungs. This is often from aspirating bacteria from the mouth. You can also see this in lung abscesses as well. And I talk about these things in other videos. And then there are a number of viruses that can cause pneumonia. This includes influenza, SARS-CoV-19, and respiratory syncytial virus. The signs and symptoms of pneumonia are fairly straightforward. Most patients have a fever and a cough. They often produce sputum. If you do a complete blood count, you typically find an elevated white blood cell count. And then many patients develop pleuritic chest pain. So this is pain with inspiration. That's because you're stretching the inflamed, infected lung tissue, and that can cause chest pain. So the diagnosis of pneumonia is usually made through the history, the physical exam, and the chest x-ray. The history will include things like cough and subjective fever. There are a number of physical exam findings in pneumonia. I talk about these in detail in another video. And then the chest x-ray will show findings like what's here that indicate a lobar or bronchopneumonia or whatever. Rarely these other tests are done, like a CT scan. Sometimes we culture the sputum to identify the bacteria, but we don't do this most of the times. And then bronchoalveolar lavage is a test where you insert a bronchoscope, a camera, down into the lungs, and then you can wash the lungs with fluid and take a sample of that fluid and send it to the lab. And this can be used to identify specific bacteria causing infection. So earlier in this video, I talked about pathologic classes of pneumonia like lobar and bronchopneumonia. Now I'm going to talk about clinical classes of pneumonia. This is different, and these classes are very important for how we select antibiotics to treat pneumonia. So in terms of clinical classes of pneumonia, We can split cases of pneumonia into two types, community-acquired and nosocomial. So community-acquired means that the patient was out in the community, they were at home, at work, and they acquired pneumonia. These types of infections are usually caused by strep pneumoniae, Haemophilus influenza, or Staph aureus, sometimes the atypicals like these bacteria here, which I discussed earlier. Nosocomial infections occur among patients who have been hospitalized or in a nursing home. These infections typically are more serious. They're often caused by bad bugs like gram-negatives, like these bacteria here. And we can split nosocomial up even further into hospital-acquired, ventilator-associated pneumonia, which occurs in people on a ventilator, or healthcare-associated pneumonia, or HCAP. This is pneumonia that occurs in nursing homes. When we're selecting antibiotics for community-acquired pneumonia, we subdivide community-acquired pneumonia into two different subtypes. The first is so-called uncomplicated community-acquired pneumonia. This occurs in patients who have no significant comorbidities like COPD or chronic kidney disease or all these things listed here. Also, they have to have no recent antibiotic use in the few weeks preceding the infection, and that's because antibiotic use increases the likelihood of a resistant bacteria. And then finally, there have to be low community rates of resistant bacteria. And so if the patient meets all three of these criteria, then we say that they have an uncomplicated case of community-acquired pneumonia. And in these cases, some of the antibiotics that are typically used are azithromycin, clarithromycin, or doxycycline. These antibiotics target the bacteria that commonly cause community-acquired pneumonia like strep pneumoniae, H. influenzae, and atypicals. Patients usually take a 3 to 5 day course, and they should be afebrile after 48 to 72 hours of treatment. If they're not, it implies they may have a more complicated infection. Contrast that with complicated community-acquired pneumonia. So this occurs in patients who have any of these comorbidities listed right here, or among patients who have recent antibiotic use. In these cases, there's a higher likelihood of bad bacteria that are resistant to antibiotics. So some of the antibiotics we use include fluoroquinolones like levofloxacin. Sometimes we use amoxicillin plus azithromycin. And the idea here is to cover beta-lactamase producing bugs. So there are variants of H. flu and M. catarrhalis that can produce beta-lactamase. Also, methicillin-susceptible Staph aureus can produce beta-lactamase. And so in these cases of complicated community-acquired pneumonia, we use different antibiotics like these listed here. And then lastly, in nosocomial pneumonia, you have to choose antibiotics, keeping in mind that resistance to antibiotics is very common. So these patients often have infections with gram-negative rods, which can be resistant to antibiotics, bacteria like these listed here. They can have infections with Staph aureus, including methicillin-resistant Staph aureus. And so in general, when you're choosing antibiotics for nosocomial pneumonia, you often have to choose antibiotics that cover or treat Pseudomonas and MRSA. There are lots of options for how to do this. They're not going to expect you to pick antibiotics for these bacteria on step one, but you should be aware that we often use multi-drug combinations that are given intravenously in the hospital. Some of the things that can be used are shown here: cefepime or ceftazidime, imipenem or meropenem, or piptazo. And I talk about all these antibiotics in detail in the infectious disease section. Let's talk about some of the complications of pneumonia. So the big one is sepsis. Pneumonia is one of the most common causes of sepsis. This occurs when bacteria reach the bloodstream and trigger a massive inflammatory response, and this can potentially lead to organ failure and shock. Pneumonia can also cause respiratory failure, so many patients with pneumonia require ventilation in the intensive care unit for a period of time until their pneumonia improves. You can get a lung abscess from pneumonia, pleural effusions can develop, and lastly, ARDS is the acute respiratory distress syndrome. This is a classic complication of pneumonia, although it can occur in response to other things, so let's talk about this now. So ARDS, or the acute respiratory distress syndrome, is a pulmonary syndrome triggered by a number of lung injuries. One of them can be pneumonia, but there are others. The way this develops is the injury leads to release of pro-inflammatory cytokines, and the cytokines draw neutrophils into the lungs. And then the neutrophils release toxic mediators, things like reactive oxygen species and proteases, and these things damage the capillary endothelium and the alveolar epithelium, and this leads to proteins escaping from the vascular space, meaning from the blood, into the alveoli. Once proteins get inside the alveoli, they draw fluid in, and so fluid pours into the interstitium and the space surrounding the alveoli. So key things to remember about the pathology of ARDS is, first of all, that protein escape from the blood is key. and that draws fluid in, and so you get pulmonary edema, but this is through a different mechanism than the pulmonary edema you see in heart failure. That pulmonary edema comes from high pressures. In ARDS, the pressures in the capillaries are not high. The problem is that these proteins are escaping and they're allowing fluid to pour into the interstitium. There's a classic pathology finding when you examine lung tissue from patients with ARDS, and that's the presence of intraalveolar hyaline membranes. If you look at this slide on the screen here, the arrow is pointing at one of these membranes. So these spaces in here are the alveolar spaces, and they should be surrounded by very thin walls. But instead, they're surrounded by this thick pink material here. That's an intraalveolar hyaline membrane. It contains protein-rich glassy deposits, and by this I mean it's filled with fluid and proteins. It's very sticky, and that's what spills out of the capillaries and surrounds the alveoli in patients who have ARDS. So in ARDS, fluid leaks into the air spaces, so these patients have pulmonary edema, but it's non-cardiogenic pulmonary edema, and we use this word non-cardiogenic to differentiate the pulmonary edema of ARDS from the kind you get in heart failure. In the videos in heart failure, I talk at length about how those patients develop pulmonary edema because they have high pressures in the pulmonary capillaries. In ARDS, high pressures are not the problem. Instead, fluid is leaking out of the capillaries into the alveolar air spaces. Because of all the edema, there will be decreased compliance of the lungs. Basically, the lungs become very stiff. And then hypoxia will cause vasoconstriction of blood vessels in the lungs, and so this will raise the pulmonary vascular resistance. And then all that edema will wash away surfactant. The alveoli can collapse. When you have blood flowing past collapsed alveoli that are not filled with air, this leads to shunting, which is one of the mechanisms of hypoxemia. And it's very high yield to know that although there are many reasons patients with ARDS become hypoxemic, shunting is one of the best described in the literature. And so ARDS is a complicated condition to manage in actual patients, but everything I've listed on this slide is super high yield stuff for your STEP exam. This is what they're going to want you to understand about ARDS. They're going to want you to understand how it affects lung compliance, vascular resistance, and how it leads to shunting and hypoxemia. So there are many, many triggers for ARDS, but on this slide I've listed some of the important ones that I think are worth knowing. So sepsis is the most common cause of ARDS. Many patients with sepsis or septic shock develop ARDS and require mechanical ventilation. Other infections can also trigger ARDS, so can aspiration, trauma, or acute pancreatitis. It's been described in heat stroke. It can complicate eclampsia in women who are pregnant. Anyone who has inhalation injury, for example, someone who inhales lots of smoke from a house fire, can develop ARDS. And then it can also happen in patients who have TRALI, or transfusion-related acute lung injury, which is a reaction to a blood transfusion that I talk about in the hematology videos. So ARDS is usually diagnosed clinically based on criteria that were originally called the Berlin criteria. They've since been modified and updated a number of times. But some of the important elements of the diagnostic criteria for ARDS are shown on this slide. So first of all, the patient has to have an abnormal chest x-ray showing pulmonary edema, like this x-ray right here. You can see that bilaterally in both lungs, there are white infiltrates or opacities. That's what you see in pulmonary edema, whether it's from ARDS or from heart failure. The x-ray will look just like this in both of those conditions. Another criteria is the respiratory failure has to occur within 1 week of the insult. So if a patient had sepsis or trauma and months later develops something like this, that wouldn't be called ARDS because it has to occur within a week of the insult. Another very important criteria is a decreased ratio of PaO2 to FiO2 such that it becomes less than 300. Let's talk about what this means. So the FiO2 is the fraction of inspired oxygen. In a patient breathing room air at sea level, the FiO2 is 0.21 or 21%. In a patient on a mechanical ventilator breathing 100% oxygen, the FiO2 would be 1. And then PaO2 is the partial pressure of oxygen in the arteries. You obtain this from a blood gas. And that's going to be low in ARDS because the patient has hypoxemia. And the FiO2 can go up in ARDS because you have to give the patient more and more oxygen to maintain their oxygen level. So this ratio of the PaO2 to the FiO2 goes down in ARDS and has to get less than 300 to meet criteria for the diagnosis. And then lastly, the symptoms can't be from heart failure or fluid overload. So remember what I said, this x-ray right here could also occur in a patient with heart failure. If you're going to call this chest x-ray ARDS, then there can't be other evidence of heart failure for the patient. So for example, the BNP level should be low or normal. There shouldn't be jugular venous distension. If you measure the pulmonary capillary wedge pressure, it should be low or normal. Keep all these things in mind because they could ask you about this in a board question by showing you a patient with ARDS and asking which of the additional findings should be true. And it might be some of these findings here, things that need to be absent for the patient to have ARDS. And then I've summarized the key point about this X-ray on the slide here. It looks like pulmonary edema, which it is, but the pulmonary capillary wedge pressure is normal or low. It's not high like it would be in heart failure. And then I'll finish with one slide on the treatment of ARDS. This is a super high-level topic. Treating these patients in the ICU is very complicated. They almost always require mechanical ventilation. And there was an important trial several decades ago that showed that these patients benefit from a low tidal volume when they're on mechanical ventilation. So what this means is on a mechanical ventilator, you can set the tidal volume at whatever level you want, like 300 cc's or 500 cc's. And the studies have shown that using a lower tidal volume is better for the patient than a higher tidal volume. It's thought that when you use a higher tidal volume, you overexpand the alveoli, and this can cause what's known as barotrauma that worsens the condition. So when you're selecting the ventilator settings for a patient, you try to choose a lower tidal volume and a higher respiratory rate rather than a higher tidal volume and a lower respiratory rate. And then these patients usually need supportive care. They often need IV fluids. They often need IV nutrition. And one of the most serious complications, one of the things you worry about, is that ventilator-associated pneumonia, which is a very complicated form of pneumonia, can develop as a very serious and life-threatening complication. And that concludes our first module on pneumonia.